evening, all. My name is Simiran Choudhary, and I welcome all the viewers and speakers on behalf of Voice of Healthcare. And thank you all for joining in for the panel discussion on Embracing Pink Beyond the Ribbon, a virtual awareness initiative for breast cancer awareness in India, organized by Voice of Healthcare and co organized by Pfizer. The initiative Embracing Pink Beyond the Ribbon signifies our collective effort to talk and raise awareness throughout and not just on recognized awareness days. As we all know, breast cancer is the most common type of cancer amongst women in India. According to World Health Organization, breast cancer caused 670,000 deaths globally in 2022. Roughly half of all breast cancer occur in women with no specific risk factors other than sex and age. Approximately zero point 0.5 to 1% of breast cancer occurs in men. With this panel discussion, we, with our esteemed speaker, aim to raise awareness and educate public in layman's language about what is breast cancer, who is at risk, signs and symptoms, timely diagnosis, advanced treatments, and challenges and disparities in access to breast cancer care to underdeveloped areas. Now, I would like to introduce our esteemed speakers for the panel discussion. Dr. Akansha Choudhary, Consultant Medical Oncology and Hematology, AIIMS, Bhopal.
Hello, everybody. Good
Good
evening.
evening, ma'am. Dr. Atul Batra, Additional Professor, Medical Oncology, AIIMS, Delhi.
Hi, good evening, everyone.
Good evening, sir. Thank you for joining. Dr. Aditya Sarin, Associate Consultant, Medical Oncology, Sri Gangaram Hospital and Research Center, Delhi. Good evening, doctor.
Good evening. Good evening, everyone.
Thank you so much for joining, sir. Dr. Jatin Sarin, Director, Medical Oncology, IVY Hospital, Mohali.
Good evening, everyone. Good evening to my fellow panelists.
Good evening, sir. Thank you for joining. Dr. Brigadier B.N. Kapoor, Director, Medical Oncology, Yashoda Superspeciality Hospital and Cancer Institute, Ghaziabad.
Hello, good evening, everybody. It's a pleasure to be part of this panel. Thank you very much.
Thank you so much, sir, for joining. Now, I would like to begin my panel discussion with Dr. Akansha Choudhary. Ma'am, can you please explain the biological process behind the formation of breast cancer cells and how is breast tumor different from breast cancer? Ma'am, you're on mute. Ma'am? Ma'am, you are on mute, ma'am. Akansha, ma'am. Yeah.
Okay.
Okay.
Yeah. So I would like to begin the answering the question like first, how a cancer develops, and then how a breast cancer develops. So when there's a normal cell that undergoes a regular cycle of cell division, and after some times that cell gets arrested, and because of the growth arrest, the cell cycle stops and it exits the cell cycle. However, in cancer cells or malignant cells, this cycle is distorted. The cells keep on going this cycle of division, and they do not undergo differentiation. So the cell becomes mad. In common man's language, you can say that the brain of the cell, that is the genetic material, the DNA, there's a problem in that. Hence, the cell cycle gets repeated, and because of this division, a number of cells are formed, and it is for common man. That is why we have a lump, a growth that forms of so many cells. While if it's a normal thing, that growth will not form. Once the cell loses its brain, the cell will die off. This is why a cell, this is the process how a cancer is formed. Now coming on to breast cancer. So breast cancer arises from mostly the duct cells. Breast cancer anatomy we will go to. Breast has got number of ducts and lobules. Lobules are this kind of thing that opens into a duct, a tube like lining, and the lining of this tube This gives rise to the most common form of cancer, that is IDC, invasive ductal carcinoma. So this is how a breast cancer develops, and there are various theories like stem cell is there, which can differentiate into all those other cells that loses its mind, I can say in the common man's language. Okay, so that's the answer to your first part of the question. And now I think I'll start with the second question. But yeah, one thing before that. Also, for this going crazy of the cell, there it's not just one thing, one event that causes a cell to become crazy. It's multiple events, multiple insults, and these insults cause repeated damage to the cell, and the cell loses its mind, and then it goes on dividing, as I told you. So repeated insults can be in various forms, like it can be because of some chemical, it can be because of radiation, or genetic, or even some other anything that basically that is a carcinogen that causes these events to happen multiple times. So first step is like promotion initiation, and then multiple insults will keep on promoting. If this is not stopped, then it causes cancer. If it's just one initiator, stop, the insult stops, it will not cause a cancer. Initiation, one promoter, it will not cause the cancer. Multiple insults over a long period of time, that causes cancer. Okay, so now I think I'll begin with the second part. What is the difference between breast cancer and breast tumor? So tumor is basically a general term which can include the cells which are, so dreadful, malignant, which is cancer. And but it can also include some terms like which are not so dreadful, which is just an aberration of the normal, just a mass of cells which is not so detrimental to the patient, which will not cause a threat to his life, which does not have to be dealt with so aggressively. Those also can be included in tumor. However, for common man, they often confuse it, like breast tumor is equal to breast cancer. So the tumors, for tumors, what there's a term, what they say is something which is the vague mass of tissue, vague mass of cells. That is a tumor. So among breast tumors, there are various tumors. Some of the benign tumors include fibroadenoma, papilloma, galactosele. It further is characterized whether it's so harmful, it is not so harmful, it is like okay to deal with. In common man, the term that we use for it is whether the lesion is proliferating or non-proliferating, and further whether there is hyperplasia or no hyperplasia, and all these may have different risk for progression into breast cancer. So about the common tumors that can be seen in breast, which are not malignant, is fibroadenoma. In fact, 50% of the breast biopsies that are done, thankfully, they turn out to be fibroadenoma. And something which I can say for fibroadenoma is it's another name is breast mouse. So the thing is, it moves easily in the breast. It's a small tumor, or maybe sometimes big size also. You can have a vague fullness, increased consistency, and it is found in the age group of 15 to 35 years of females. uh, and often it can be associated with tightness or discomfort in the breast, which coincides with menstrual cycles of the lady. So in order to but for a common man, any lump that you feel in the breast, it is very, very important that you consult a doctor, take an opinion. We will examine you, we will see how it feels to us, first thing. Second thing, we'll subject the patient to undergo mammography. And third thing, if we still feel it is suspicious or something is doubtful, then the patient will be undergoing a needle test. That can be in a form of FNAC or biopsy. And further, we'll be discussing on all those things.
Thank you so much, ma'am, for explaining this in a very simple language to us and to our audience so that they can understand and have a brief idea of when to consult a doctor and what exactly it is. Moving on to my next question to Dr. Atul Batra. So, what are the different types of breast cancer and how do they vary in terms of origin and characteristics? Why and how important it is to distinguish between these types of cancer for treatment purposes specifically?
So, thank you. And so, this was actually the most important discovery that was done, that breast cancer is not one type. होता क्या है कि breast cancer is divided into several types. Those are all for research purposes. We can keep classifying them. But for clinically, what is important is that we classify them broadly into three types. One is hormone receptor positive, which is estrogen and progesterone are the hormones that are secreted in females, and there are receptors that are present on these cells. So basically, these cancer cells would feed on any amount of estrogen or progesterone that is present in the body, mainly by the estrogen. So these are typically known as hormone receptor positive. These account for around 50, 60, 70% of all the tumors. The second type is HER2 positive. So there is a specific kind of receptor which is HER2, and these are again around 15 to 20%. Some data from Indian population shows that it is around 25%, some 30%, so a little higher on that end. And the third type is triple negative. So as the word suggests, triple negative, that means ER, estrogen receptor, PR, progesterone receptor, and HER2. These all three are negative. Now, this is the most aggressive form of breast cancer that we know today. And since there are no targets here, and there are some peculiarities associated with each and every type of breast cancer subtype. For example, like triple negative breast cancer would typically present in younger patients and would present more in more advanced stages. It has a higher proliferative rate. That means it grows at a very fast rate. It is quite chemo. There would be responses to chemotherapy that would be short-lived. So the recurrence rates are higher. It has a higher tendency to go to brain and other organs. So it is typically associated with those hereditary breast cancers that we talk about, BRCA mutation and all those types. And this tumor is treated very aggressively because the patients are young. There are higher chances of recurrences later on in life. This accounts for around, again, 20-30% of patients. In India, there's a younger demographics at present, so there are more triple negatives. So this increases the burden on young patients, where again, they have several other challenges to meet at a younger age. The HER2, the previous one that we discussed, this has a target which is HER2, and there are several drugs which are available, like trastuzumab, we call it Herceptin, pertuzumab, so on. I mean, there are a lot of drugs that act on this receptor itself. So if the patient has this positive, is positive for these receptors, then they are treated with additionally these targeted therapies. And if you compare the outcomes of patients when these targeted therapies were not available vis-a-vis when these therapies have become available, they have improved markedly, right? The knowing that this receptor is present gives us the power to use these agents, which are called targeted therapy, and their action is mainly on the cells that have this receptor. So these are again, there are some peculiarities like more tendency to go to brain. These are also kind of aggressive tumors. But with the availability of all these newer agents, it has become possible to treat them aggressively and have a better outcome as compared to the past. Coming back to the most common type, the hormone receptor positive, the name itself suggests that these are dependent on hormones. So if these hormone receptors are positive, then they are treated up. These patients actually may or may not even require chemotherapy at a very early stage. If they are diagnosed, surgery and just hormone therapy may be enough. We look at several details. I think that is beyond the scope to discuss today. But many patients where hormone receptors are positive and they are early stage, chemotherapy can be avoided and they can be treated with hormone therapy after surgery. So that is important. And since it is dependent on hormones, The treatment includes some oral agents that either block these hormone receptors or cause decrease in production of hormones in the body. Sometimes we take ovaries out or do it medically to kind of target these. There have been several developments in all these three types of cancers. Like immunotherapy has come up in triple negative. There are targeted agents, PARP inhibitors in triple negative, CDK4/6 inhibitors. I mean, just to tell you how science has progressed, and if we didn't know that it was a different kind of disease in every patient, we wouldn't have ever gone into that. So, a biopsy, when there is a high clinical suspicion initially, we typically recommend to do a biopsy rather than a fine needle aspiration, because it is extremely, extremely important that we know whether the patient is triple negative, hormone receptor positive, or HER2 positive. Even in patients that have very small tumors, like 2 to 3 centimeters, that can easily be taken out, are treated with chemotherapy first in case of triple negative and HER2 positive. So, I mean, it gives us a lot of power to take those decisions and improve their outcomes. If we know that what subtype is there, the whole treatment plan just is dependent on this. So it is extremely, extremely, extremely important that we know what type of tumor is it. And a big message would be not to go straight away with surgery without knowing what type of tumor is it, because there are several other ways. There is a paradigm shift in how we manage breast cancer now, and knowing it is extremely powerful.
Thank you so much, Dr. Atul Batra, for explaining this and in depth so that we have a better understanding of this. Moving on to my next question to Dr. Aditya Sarin. Sir, what are the risk factors which contribute to development of breast cancer, and how do genetics, environmental, and lifestyle factors play a role in this? Also, are there any certain population which is more prone to developing breast cancer?
Yes. So let's break it down. And first, let's discuss all the risk factors. So there are those risk factors which we can modify, which we have the power to have inculcate in our daily activities. And there are some risk factors which are non-modifiable, which you can't help, and you have to just stay with them. So starting with the non-modifiable risk factors, so the factors like the patient is having increasing in the age, so higher the age, female sex, and a positive family history, certain genetic abnormalities. So now you know that these are those risk factors where you can't do anything about them, you just have to live with them. Now, coming on to the modifiable risk factors, so obesity being one of the major ailment which we are seeing that has a high tendency to develop cancer, and especially in females. And now that the eating habits have changed so much in the past few years, and I think obesity is having a positive correlation with the development of the tumor. Followed by that, patients on hormone replacement therapies, patients who are having addictions and they're having lifestyle modifications like alcohol consumption, smoking, and more of a sedentary lifestyle, they are all prone to develop breast cancer, and these have already been proven with a strong association with the development of the breast cancer. So because you can modify these factors, so that is why they are known as modifiable risk factors. Now there are those certain risk factors as well. The patient comes to us and they ask, doc, does it really matter if I do this or that? So those factors which do not influence any breast cancer risk is number one, caffeine intake, hair dyes, in vitro fertilization, and any history of abortion, tubal ligation. So I think these are those factors where patient or the women is not supposed to worry about, because it has never been proven that any of these modality is going to create any trouble for them. Now, let's say a patient comes to us and they ask, doc, I have not been diagnosed with the breast cancer, but how will you assess that I'll be a patient in future, that my tendency to develop breast cancer is high? So number one, we need to analyze their personal history. their family history, and we have certain tools where we have our online calculators, and in mobile as well, we can use those specific calculator, and then we can stratify the patient into average risk, moderate risk, or a very high risk. As after the classification, you can definitely plan their screening programs better, and I think speakers will take this point up ahead. But if I have to say for a one patient, the main thing is the personal history of any cancer, like breast cancer, ovarian cancer, or a tubal cancer or peritoneal cancer, a family history of breast cancer, ancestry, like so not relevant much in India, but yeah, some Jewish ancestry along with the history of BRCA1 or BRCA2 in the mutation. And we all know about the Angelina Jolie effect, and it happened like a few years back, and both the surgeons and the oncologist got huge number of wake up calls from that. And in fact, in that particular area, if we were to look at the rate of mastectomy, it was quite high because of the excessive, you can say, awareness about the topic. So genetic mutations like BRCA1 and BRCA2, if they are inherited, so then definitely the patient is a higher risk of developing breast cancer. And now reproductive factors like early menarche, or late menopause, and number of pregnancies. So nowadays, which we are seeing a lot of the time, that in a family, that females are conceiving in a later part of their life. If conceiving happens after 34 or 35, so there they see that there is a 5% increment in the risk of developing breast cancer in those subgroup. So these are those reproductive factors which need to be taken account, and the patients, we counsel them whenever the need arises. And with this, the final point that you asked, that what are the certain population which are more susceptible to developing breast cancer? I think I have rightly told in the beginning: genetic factors, your personal history, your modifiable risk factors. We pool them into one algorithm. By we have so many tools like BRCA Pro or Klaus or Cruzy tools, and we can just formulate their average risk or a high risk, and we can plan further treatment as per that.
Thank you so much, Dr. Aditya Sarin, for shedding light on this important topic. And to move on, I would like to ask Dr. Jatin Sarin. So, can you please describe the staging process and the criteria used to classify each stage? And how does the stage of breast cancer impact the treatment plan and prognosis?
Well, broadly, breast cancer is staged just like all other solid cancer. You have to stage according to the size of the lump of breast tumor, and according to its spread. That is, it has either spread. The first station where the breast cancer spread is the lymph nodes in the armpits or axilla, as they say. So this staging is done according to the size and the extent of lymph node spread. So if it is localized to breast only, it is either stage 1 or stage 2. And if it has spread to lymph nodes, it becomes late stage 2 or stage 3. And if it spreads beyond this loco-regional area, that is spread to distant organs like lung, liver, bones, brain for that matter, it becomes stage 4. Now, breast cancer staging is not just by, it differs from the rest of the cancer staging. It is just as alluded by Dr. Batra previously, that, breast cancer is subtype according to the kind of receptor present on them. So, for in our this thing now, we are having a different stage based on the different receptors also, different receptor status of the tumor also. So a triple negative always, even if you are having a similar tumor, or a similar number of nodes, a hormone receptor will be always staged better as compared to a triple negative breast cancer. So stage has a very important bearing not only on the prognosis of the disease but also on the treatment of the disease. Very early stage, hormone driven ERPR strong positive stages, you can even straight away take them for surgery. But for the rest of the stages, for rest of the stages and their types, like specifically triple negative and HER2 new receptor subtype, one should not go for surgery straight away. You need to downstage it, because the treatment and the prognosis in future, that is post surgery, what you get with the previous treatment of chemotherapy or targeted therapy, whatever, the treatment and prognosis, further treatment and prognosis depends largely on the result of the previous treatment given, that is the treatment given before surgery. So that is an important concept, and that is the important thing to make the people realize that it is not just simply the stage. No two breast cancers are same. You have to stage them, you have to classify them or subtype them according to the receptors, because it helps us to tailor the treatment accordingly, so that we can have optimal results. There should not be an over treatment, and there should not be an under treatment. So an optimal treatment should be given. And even the follow up also, sometimes matters. You have to follow it up. Suppose there are higher stage cancer, you have to follow them up quite intensively, and you are at a guard always. So staging and subtyping go hand in hand, and they really matter as far as planning that treatment to achieve the best results in breast cancer.
Thanks a lot, sir, for explaining us that in a very simple language so that we all can understand this. Moving on to my next question to Dr. Brigadier B.N. Kapoor. Sir, I would like to know what are the common signs and symptoms of each stage, and how do treatment approaches vary between early stage to advanced stage of breast cancer? Sir, you're on mute.
Yeah, breast cancer is very easy to diagnose because the organ is visible and one can diagnose it very early. The signs and symptoms of breast cancer, I must say, the initial symptoms will be some swelling in the breast, some lump in the breast, but one should remember that the lump which is there in the breast is generally painless initially. So any lump in the breast which is painless, one should be very, very suspicious, because generally the patient goes to the doctor whenever there is a pain. A patient prefers not to go to the doctor if there is no pain. So one has to remember that a painless lump in the breast is uh, is a worrisome thing, and one should contact doctor. The symptoms of the breast cancer generally depends on the stage of the disease. Initially, when it is at the early stage, it is localized to the breast. There is a lump or swelling in the breast. There may be nipple discharge. There may be dimpling of the breast, which we call as putty orange, or the orange peel-like appearance of the breast. There may be some peeling and of the areola, or some discharge from the nipple, which generally denotes that probably one is suffering from. These are the early features of breast cancer. When the breast cancer increases, or when the stage increases, when it becomes locally advanced, what we call, then it involves the lymph nodes. And the lymph nodes are the swelling which is generally start in the axilla. Of the same side axilla, there may be a lump. And thereafter one can feel it in the clavicle, that is the collarbone, above the collarbone, below the collarbone, and the lump appears in the axilla and the uh, uh, collarbone, above the collarbone and below the collarbone, what we call as supraclavicular lymph node and intraclavicular lymph node. These are the initial features of breast cancer. But in the advanced stage, what we call as metastatic, when the disease spreads to the other part of the body, generally the breast cancer goes to the brain, to the lung, to the bone, and to the liver also. And if the patient disease spreads to the bone, generally it goes into the vertebral column, to the spine. They generally complain of backache, and if they ignore it, then it many a times it causes paralysis of the lower limb, and it causes paraplegia. So one has to be very, very, if there is a backache, a person is having breast cancer, suspicious of breast cancer and develop backache, one should go in for investigations like PET scan and other investigations and the MRI, and to diagnose whether the disease has spread to the spine or not. If the disease spreads to the brain, then the symptoms are related to the according to the brain. Generally, these patients present with severe headache, vomiting. They come with seizure, fits. They come with fits, and then we do the MRI of the brain, and we found that the disease has already spread in the brain. uh, it may spread to the lung. We find few cases of breast cancer spreading to the lung. They cause what we call as lymphangitis carcinomatosis. The breast cancer spread extensively in the lung, and they develop breathlessness, they develop cough, they develop many times, sometimes hemoptysis also, and then we have to investigate accordingly. So these are the common signs and symptoms of breast cancer. They basically depend on the early stage, at later stage, then what we call as locally advanced breast cancer, and metastatic. And the treatment of breast cancer is different in all the stages. I must say the early stage breast cancer, when it is localized to the breast, if they are hormone positive, as my previous speakers have told, we can go in for surgery initially only. But when it is triple negative, ER negative, PR negative, HER2 nowadays we downstage the tumor. We reduce the tumor by giving chemotherapy, targeted therapies, and once the size reduces, then we go in for surgery. Treatment of locally advanced, if there is an lymph node involvement, whether it is ER positive, PR positive, we downstage by giving chemotherapy, then go in for surgery, and thereafter will require radiotherapy also. So all three modalities of treatment are required in the treatment of breast cancer: surgery, chemotherapy, and radiotherapy. And if the patient has got the metastatic disease, if it has spread to the other part of the body, probably chemotherapy is the mainstay of treatment in such patients. And if they develop brain metastasis, they will require brain radiotherapy also. And if they have developed severe backache and spinal compression or paraplegia, they will require radiotherapy to the spine also. So these are the common modalities and the common signs and symptoms of the breast cancer.
Thanks a lot, sir, for explaining the signs and symptoms to us according to the stages so clearly. I would like to move on to my next question to Dr. Akansha. Ma'am, why is it important to get regular breast cancer screenings, especially for women? What are the different methods of breast cancer screening and how do they exactly work? At what age should individuals start getting regular mammograms? I would request all the speakers to please switch on your cameras.
Okay, that's really nice. More important to the population that we are addressing. So for no, for a women who is at average risk of getting a breast cancer, uh, the screening guidelines from US Preventive Services Task Force says that 40 to 74 years of females should undergo regular biennial screening mammogram. Biennial means once in 2 years. So every 2 year, a female starting from 40 to 74 years of age should undergo this screening mammography And screening mammography has got uh, correlation with ultrasound also. So usually they will do sonomammogram. And for patients who are at high risk of getting breast cancer, that includes, as initially told, patients from Ashkenazi Jews races or family history, or those who have known BRCA mutations or some other syndromes like Cowden, Leapfrog, should begin screening early. And there's also something which is screening by MRI. So that also in that I had mentioned, that BRCA patients with BRCA radiation, BRCA or those who had received radiation before 30 years of age, such patients undergo screening by mammogram.
Ma'am, I believe there's some error in your connection. Can you hear us, ma'am?
Okay.
Can you hear us?
Yeah, I can hear you.
Yes, ma'am.
Think. Shall I? Hello.
Yes, ma'am. We can hear
Now
you. You
is
can
it better?
continue, ma'am. Yes, ma'am. We can hear you.
Okay. Maybe I think. Can you hear me clearly?
Yes, ma'am. We can hear you clearly. You can continue.
Okay. 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 So I'll repeat. For women of who are at average risk of getting a breast cancer, they should undergo screening mammogram once in every 2 years, beginning at the age of 40 years, and this has to be continued till 45 years, till 74 years of age. After 75 years of age, there's no clear benefit of screening. So the most women in the age group of 40 to 74, every 2 yearly mammogram. Okay. And those patients who are at high risk of getting breast cancer, that is including, as mentioned earlier, patients from Ashkenazi Jews family, or those who have a family history of breast cancer, or those who have a known family history of BRCA mutation, or some syndromes like Lee-Fromani, Cowden. Such patients have to undergo screening with MRI, and that screening has to begin earlier, around 30 years of age. Some patients even 25 to 30. It varies. But for
Thank you
average
so much.
risk, it begins at 40 to 75. Yeah.
Thanks a lot, ma'am, for explaining that to us. I would like to move on to my next question from Dr. Atul. So, what are some of the latest advancements in breast cancer screening technology? How have these advancements improved early detection rates and patient outcomes nowadays?
I think if we talk about screening modalities that have already been discussed earlier, most commonly used and accepted one is mammography, and there have been several advancements even in the within the mammography. So digital tomosynthesis, which creates a better kind of picture, and most importantly, now what is entering in the mammogram is the utilization of artificial intelligence. It is still in kind of being studied further, but it has a huge potential to kind of get into it. There are several studies that have been conducted because these lesions that are there in the mammogram are quite small and they need a very good eye, and AI can definitely assist, if not do that independently in detecting such lesions. So I think we look forward to see AI serving a much more important role with mammography. The second one is MRI. MRI is availability is a big challenge. Even for mammogram, there is a big challenge using mammogram throughout our country. There are much limited number of machines that we have to cover the whole of our country, and there are some projects conducted. Even our teams, New Delhi has taken a lead into doing that, where we're using kind of ultrasound devices, and it does not show the uh, screen does not show the images, but just gives you a kind of red or green signal that a green signal is fine and a red signal needs further evaluation, where the patient would be referred, the not a patient till now, the female would be referred to kind of hospital to get further evaluation. So there are several advancements, and we need such kind of novel technologies because of the limited infrastructure that we have to serve our rural areas, the availability of mammography machines, the availability of radiologists. These are the technical challenges that we have in doing a universal breast cancer screening program. It's easier said than done, but the penetration has been a big challenge, not just because of awareness, but also because of the limited infrastructure as well. But we are moving in the right direction, and we hope that within a few years we should be covering most population.
Thank you so much, sir, for explaining this to our audience and us. My next question is to Dr. Aditya Sarin. So, can you discuss some examples of targeted therapies and their effectiveness to the patients while they are under the treatment?
Yeah, so I think evolution is the only way in oncology. The way I'm looking at it, in the past 20 years, oncology has taken leaps and bounds. And initially, if we were to look, 20 years back, so there used to be hardly any targeted therapy. There was no mention about immunotherapy. Even immunotherapy was in the research phase. And over a period of time, as the science has evolved, so we have better drugs at our disposal, and these are readily available in India. Hardly few of the drugs are there which are not available, but that I think 80 to 90% are there in our day-to-day clinical practice. And I will take it, stepwise manner, because targeted therapy, what it really means is that they are able to identify one specific point on the cell and they are going to hit that. So starting with the hormone therapy, and earlier we used to use letrozole or tamoxifen, and now with more understanding and more background knowledge of how the cell cycle works and replicates in these kind of subgroup which are hormone receptor positive, we have drugs and tablets which are known as CDK4/6 inhibitors, and well tolerated by the patients. In a patient who is already having a stage 4 metastatic breast cancer, and we initially get approval for a stage 4 kind of a breast cancer, and these are just simple tablets which they have to consume in their daily routine, and we are seeing OS benefits and survival benefits to the tune of 5 years and 6 years. These tablets, they don't cause any hair loss, no loss of appetite, and no chemotherapy related side effects. So these are well tolerable, though there are uh, disadvantages with one or few of the drugs with cardiac toxicity, or some might have diarrhea, but mostly are well tolerable. Even in stage 4, where your disease has gone to rest of the body, and they are able to capture and kill those cells where these kind of hormone sensitive tumors lie. Now, coming on to another point, the most revolutionary thing for us medical oncologists is anti-HER2 neu. Anti-HER2 neu is the another target where we are using drugs like trastuzumabs, and we started to use this drug like 10, 20 years back. It took them for new molecules. Very recently, we got pertuzumab. I think it's been now 6, 7, 8 years now, and now we are living in the era of antibody drug conjugates. So, not complicated. I will just
So, you're on mute. You just.
kills the cells which are tagged with HER2 receptor, and we have this information readily available before we start the treatment. So our pathologist, they give us markers on the biopsy report whether the tumor is hormone positive, ERPR, or whether it is a HER2 neu positive. And if the patient is having HER2 neu positive, we are going to use these kind of therapy. Trastuzumab was the conventional one, and it acts on the cell from the outside to the extracellular surface. Then we have pertuzumab again, and another advancement in the beyond trastuzumab. How the trastuzumab has evolved and pertuzumab in combination. Earlier, we used to give these injections, via IV route. That used to take approximately 150 minutes. And if you add the chemotherapy to it, the protocol, this used to add another, 4 or 5 hours. So the whole sum of the therapy of one agent used to be somewhere around 6 to 8 hours. And now we have the availability of drug trastuzumab and pertuzumab in a subcutaneous formulation where we have brought down the administration time to hardly 5 minutes. So for the combination, it is 5 minutes, and for the chemo, again 3-4 hours. So you can say that it has become more patient friendly. The quality of life is better, and my mostly patients are ready to adopt this therapy if they are, willing to accept it. Another drug or another blockbuster molecule that we say, and I think the rest of the panelists will also agree, because this was the drug which we have all been waiting for, the antibody drug conjugate era, where the technology has advanced so much that we are now able to attach a linker to the monoclonal body. And with this kind of a dual combination, the drug can enter into the cell which is HER2 even low positivity. So we score the HER2 status. If the patient is having HER2 1 or the patient is having HER2 2 with the fish negative, we earlier used to not treat those patients. Now with the availability of this drug, which is trastuzumab deruxtecan, we are treating and we are seeing fantastic results. Even those patients where no hope was left, and once we started to use these molecules, the patients are improving drastically. And the trial has already shown the doubling of PFS. Now the last, because this is the era and this is the most common question, I think all the panelists will also agree, the inquiry about the immunotherapy. And glad to say that immunotherapy has also found its way into the treatment lines, even in the later stage and in the early stage of breast cancer. So, what is immunotherapy? And immunotherapy is nothing where normally a cancer cell, if it is produced in a body, your body is able to identify it by the immune system and it can clear it. So, what
There's
happens
some
over the
connection.
time? It just,
Your voice was
so what
breaking a
happens
lot,
over the
sir.
time? It's still breaking a lot.
Yes, a little better.
Just a second. Then let me just do one thing. Is it better now?
So.
Yeah. So now with the immunotherapy, the point I wanted to highlight was, so our body is smart enough to kill any cancer cell that is being produced with the help of the immune system. What happens over a time, the cancer cells finds its own way to escape the mechanism of the killing by the immune cells, and that is why it starts to increase. What does immunotherapy do? It primes our own immune system, and it doesn't cause any side effect as with any chemotherapy, and it takes care also that our immune system is primed and active enough to kill those cancer cells which were initially being escaped or ignored by our immune system. And now we are using this drug in the first line treatment in the neoadjuvant setting in the breast cancer. Dr. Atul pointed out how the prodigy of immunotherapy has came into being in the triple negative breast cancer. I think it has been a fantastic journey for triple negative breast cancer. So these are few targeted therapies that we use in our arsenal, and more are yet to come. So it is the hormone therapy. We have we have advanced anti-HER2 therapy, we have antibody drug conjugates, and we have immunotherapy with us.
Thank you so much, sir, for explaining this to us. I'll move on with my next question to Dr. Jatin Sarin. So, what are the benefits and challenges of tailoring treatment plans based on these factors?
Well, the first part of your question has been aptly answered by my previous panelists. The benefit of tailoring the treatment is you get the best results by using the right kind of drugs in the right manner, and by avoiding unnecessary treatment and giving the treatment which is most necessary according to the stage and type, because of the plethora of newer drugs available. The challenge comes, what I face in my day to day practice is the first and foremost test to ascertain the type of the disease, that is the biopsy. People still have a lot of misconception regarding the biopsy, because we can only subtype the breast cancer, or not only subtype, sometimes we can confirm the breast cancer with a biopsy. There are people who still shy away from biopsy, and then they come with an advanced disease. That is the sad part of the story. And that is a biggest challenge for me, to design or tailor a treatment for that particular patient, that if you're not getting a biopsy done, how can I subtype your breast cancer? The other important thing is, when the patient comes to us, she or he is in a state of a panic, and they say, without getting staged with the radiological modalities, or without getting typed with the biopsy, they say कि डॉक्टर साहब हमारा ऑपरेशन कर दो, which is not right. I mean, first and foremost, you have to ascertain the stage, and ascertain the type. One should not
जी,
go for a surgery, as has been alluded previously also,
कोई
that these
इम्पोर्टेंट है
days
तो
you tend to give
मैं बाद में करूँ.
upfront treatment, systemic treatment, and then downstage it, and then do a surgery. So there is a sequence of treatment to be given in the right way, and that is actually called customizing or tailoring the treatment. So sometimes people panic a lot, even when we are giving upfront treatment. Sometimes patients just revolt midway कि डॉक्टर साहब आप सर्जरी तो कर नहीं रहे. So these are actually day-to-day challenges. We have to counsel the patient regularly that no, this is not the right way. You have to finish off some amount of treatment, and then we'll go to the next modality. And on the contrary, sometimes what happens, that if you get very good results with the upfront systemic treatment, say chemotherapy or targeted therapy, people tend to shy away from surgery. They say कि आपने बीमारी तो क्लीन कर दी, अब किस चीज का ऑपरेशन करोगे? So these are some actual real life challenges we encounter in our day to day practice, and I really want to convey that the treatment plan is made with the proper staging and subtyping, and there are no shortcuts to any treatment. I mean, you have to undergo whatever is required to have the optimal results. Otherwise, if something is missed out, then these diseases tend to come back.
Thank you so much for your response on that, sir. Moving on to my next question to Brigadier B.N. Kapoor. So, like Dr. Aditya Sarin explained us about the immunotherapy, I would like to know, what do you think are the success rates and potential side effects of these therapies, which are immunotherapy and hormone therapy, which is treating for breast cancer?
Uh, as my previous speakers have already told, the treatment of breast cancer is very the advances has taken place by leaps and bounds. Earlier, the treatment used to be only chemotherapy, then came targeted therapy, and then came immunotherapy. Lot of survival benefit has happened in the breast cancer management. Once, what we used to think stage 4 or stage 3 cancer, the results were not very good. But now, with the newer advanced treatment, and specifically the targeted therapies and the immunotherapy, the treatment of breast cancer has improved a lot. The treatment, like targeted therapy, depends on ER positive, PR positive, HER2 positive. We treat accordingly. We give hormonal therapy for ER, PR positive patients. We give anti-HER2 therapy for HER2 positive patients. And immunotherapy has come in a big way. The initial like triple negative breast cancers. Basically, triple negative breast cancers are the cancers where the ER is negative, PR is negative, HER2 is negative. Um, they have no targetable therapies for the management, and the immunotherapy has come a big way in this triple negative breast cancer. Even in the early stage triple negative breast cancer, uh, immunotherapy is being given to reduce the tumor size, and thereafter go in for surgery, then go in for radiotherapy if required. And even in metastatic triple negative breast cancer, immunotherapy has got a very great role. The survival has improved a lot with these treatment. With the targeted therapies, the survival has improved very much. With ER, PR positive and hormonal therapy, CDK4/6 inhibitors, like the drugs which are newer drugs which have come, the survival benefit has improved a lot. And with immunotherapy, there is 40% risk reduction in triple negative breast cancers in the early stage also. So they've come in a big way. Survival, definitely the benefit is very large. The side effects are not as much as people think. With the hormonal therapy, there are hardly any side effect when we come across the patients. They come with some DVT, some bony pains, some osteoporosis, but otherwise it is very well tolerated with not much of side effects. We do DEXA scan, we do give Zometa once in 6 months. These are bone strengthening medications we add on along with the hormonal therapy. With immunotherapy, we do encounter few side effects, but the percentage of the side effect is 3 to 5 to 7%. Generally, they develop some pneumonitis, some allergic reaction, some develop some hypersensitivity reactions, then autoimmune reactions like hyperthyroidism. Some may develop adrenal insufficiencies. Some may develop skin reactions, allergic reactions. So these are manageable side effects of immunotherapy. And generally, we give when these side effects do occur, we give some steroid, and they are very well tolerable. So the treatment has advanced very nicely, and survival benefit is there. The side effects are manageable, and I think the treatment has revolutionized in breast cancer.
Thank you so much, Dr. Kapoor, for answering that question to us and explaining the side effects and the success rates of immunotherapy and hormone therapy to us and to our audience. Now, as we are moving towards the end of this panel discussion, I would like to request each panel speaker to please give a concluding remark of this session and how does it make a difference that we all are gathered to raise awareness and educate our public on such topic which is breast cancer, starting with Dr. Akansha.
Can you hear me?
Yes, ma'am, we can hear you.
Yeah. Okay. So it's really great because breast cancer globally and in India, it's a very big problem. It's the most common cause of cancer amongst females in India and world. Most common cause of mortality also among females, both globally and in India. So definitely, it's a good effort from all of us to get together and put these points. What for a common man, what they should how they should look at it, because it's like frequently people have been approaching me like for asking for what is it, what is the cancer, how does it spread and all those things, and we don't really have time amongst our busy schedule to answer these small but important questions from one person. So this is going to me reach a large number of people, and it's going to help a lot of people. Good effort, great effort, thank you.
Thank you so much, ma'am. Next, Dr. Jatin. So, can you give a keynote to this?
Well, I just want to tell or convey this message that these days breast cancer is treatable at any stage. Even there are certain stage 4 diseases which in which you have either one or two spots some lying somewhere. They are called oligometastasis disease in our lingo. Even those cancers we approach with a curative intent. The important thing is, please don't shy away from getting your cancer sampled and subtyped, so that we can give you the right kind of treatment. Yes, there are a lot of social, a lot of logistic, lot of financial or economic constraints in our population. But within those constraints, also in India, still a breast cancer on an average can be managed in a very, very effective way. Even if we are not able to use these wonderful drugs, they are becoming cheaper day by day, and that would further enhance the results. But please don't get scared of breast cancer.
Thank you so much for that message, sir. Dr. Atul, can you please give us a concluding remark?
Thank you. So, if one liner would be early diagnosis is the key. If you feel a lump, get it diagnosed. Don't wait for it to grow into a size that becomes the treatment increases. There is treatment for all stages, but there's nothing like an early breast cancer. Your chemotherapy may be spared. There are so many things that can be done differently, and the outcome is excellent if the diagnosis is done at an earlier stage. So, one message would be diagnose at an as early as possible, and that's it from me.
Thank you so much, Dr. Atul. Dr. Aditya, please give us a concluding remark for this.
So I think I already, team panelists have given the motto behind this meeting, and I think it is definitely going to, general population, it is definitely going to have an impact. Uh, Early diagnosis is the key to the treatment. Getting a biopsy done without any hitch is the number one requirement, and you need to have your good pathology interpretation. And once that is done, I think we all oncologists, we treat the same way. Even my rest of the panelists, I think whether the patient comes to me or any other panelist, the treatment is going to remain constant. So the another myth I want to deprivate from this discussion is that if you choose your doctor, choose them and stay with them, because they are already going to treat with you with the latest standard care of guidelines, and there is no need to panic, no need for rushing here and there from interstate intrastate. I think if you are comfortable with your doctor, with your oncologist, I think for my specialty, I can say that we all are treating our patients with the latest set of guidelines, so hardly there is going to be any change in the treatment sequencing. So yeah, I think just choose your doctor and stay with them. That I would recommend.
Thank you so much for those words, Dr. Aditya. I would like to ask Dr. Kapoor, sir, please give your views on this panel discussion.
Yeah, thanks, Simran. Uh, Breast cancer, as I told, is very simple to diagnose. I have seen young girls coming very late because of just one factor, that they are shy of telling it to anybody, even to their family member. So, early diagnosis of breast cancer is the key in the treatment. And we feel very bad when the young girl comes with a large lump with fungating mass, and uh, when we investigate and found that it has already metastasized, uh, it's very disheartening to know all these things. So the awareness is very important. One should be aware of one's body. Any change happening in the body, one should immediately consult the doctor. And one more thing, which a common mistake the ladies do with breast lump, they go to gynecologist. I think gynecologist is not the right person to diagnose breast cancer. A surgeon is a surgeon, or generally a surgeon is the right person where the patient should go, because gynecologist generally the patient thinks this breast cancer is a part of gynec. Surgeon is the right person where they should go. They should get themselves investigated, and early diagnosis and treatment, and no shyness. I think there are a lot of stigma attached with breast cancer treatment and management, but that is a different thing. But early diagnosis and one should be aware of the body. If any changes happening in the body, one should immediately consult the doctor. That is the very important.
Thank you so much, Dr. Kapoor, for that great closing message to us and to our audience. I would like to thank all my panel speakers present here for taking out that time from the busy schedule and coming for this platform for this panel discussion in to educate and aware our public for breast cancer awareness so that they are more concerned towards their health and make their health a priority. With this campaign, we aim that we can educate each more and more the masses towards their health. Thank you so much for sharing your insights and experiences with us and to making this campaign successful. Thank you
Thank
so much,
you.
and thank
Thank
you
you.
all the viewers
Thank
on
you for
behalf
making this
of
part
healthcare.
of this campaign.
Thank you.
Thank you.
Thanks a lot.
Thank you.
Thank you so much. Thanks a lot for all the viewers for joining